Good evening, and welcome to the Advanced Practice, an educational web series sponsored by Medtronic. Tonight we'll be discussing driving success with the patient navigator. Thank you for taking time out of your busy day to join us this evening. This web series is intended for physicians who are currently using sacral neuromodulation and interested in learning about best practices that can help them advance their use of the therapy. This online program consists of an initial 30-minute presentation followed by a question and answer session where your questions will be addressed by our presenter. If you have a question you would like to submit, you can do so at any time during the broadcast using the Q&A widget located at the bottom of your screen. Your screen is also adjustable by moving the slide pane where it's comfortable for you. You're also able to download the slides and resources that will be referenced today by clicking the green icon below titled Resource List. At this time, I'd like to introduce today's speaker, Beth Rutledge. Beth is the Chief Nursing Officer at Urology Associates in Nashville, Tennessee. A graduate with a Bachelor of Science degree from David Lipscomb University, Beth also received an Associate's degree in Nursing with honors as valedictorian from Columbia State Community College. She's an accomplished executive with over 20 years combined experience in both marketing and healthcare arenas. She has a proven record of facilitating the design of quality patient care and implementing strategies to improve service, patient outcomes, maintain established goals, and to contribute to profitability. With that, I'll turn it over to Beth.
Thank you so much, Kendall. And I want to say good evening to everybody listening tonight. And before we get started, I want to take a moment to thank Medtronic and Urology Associates and to you all for giving me this opportunity. I am truly honored to be a part of this great effort. So as background, please keep in mind as we go through this evening that Urology Associates has been developing this OAB program for over a decade. It's a program that Dr. Abel, my CEO, and I've been working on diligently for a long time now, and through all the ups and downs, we never gave up. So for lack of time this evening, I'm only going to touch the surface to give you an overview as you all may be considering a similar program for your practice. So with that being said, let's get started. Here's my extended family, Urology Associates. We currently have 34 urologists and 12 advanced practice providers. We have 21 locations throughout Middle Tennessee and 1 ambulatory surgery center. So tonight, our goal is to take a holistic view of the treatment of OAB. We can take a step back and look at the bigger picture and think about the latest healthcare trends. How are they going to impact your hospital? How do they impact your clinic? We're moving from evidence-based medicine to value-based medicine. So how does one measure quality? How do we measure value? How do we measure patient satisfaction? So let's start by briefly reviewing the prevalence and impact of OAB in the U.S. We know that 37 million people have OAB. So many of these folks just go untreated or they get lost for many reasons. Maybe they're embarrassed. Maybe it's a lack of time. Maybe they're unaware that there's help available. Maybe they're assuming conditions will resolve on its own. Maybe they don't want to have surgery or they don't want to be a burden to their family. And yes, they even get lost in the healthcare system. So let's take it down the health continuum a bit further. Without treatment, symptoms may just start merely as being bothersome, but then they may deteriorate into a more severe condition or other health issues alongside OAB. Falls, as we know, can cause bone fractures. Exposure to urine and feces is one of the most common causes of impaired skin integrity, which can lead to an infection. And incontinence is a primary reason for admittance to a nursing home. So I ask, why do the other chronic illnesses get so much more attention? The hypertension, the diabetes, the cancers. Why not OAB when we know that there's an obvious need for standardized and comprehensive treatment plans for everyone? So if I'm an OAB patient and I'm seeking treatment in the Nashville area, I feel that I deserve the same options no matter what urologist or what practice that I visit. So tonight, let's discuss our story at Urology Associates, how we implemented our patient navigator to help us achieve our goals, and then the results of our efforts. So I want to help you guys develop a program in your practice to help retain your patients and to improve upon your quality, your patient satisfaction. So I am very pleased to announce that at Urology Associates, we have officially declared war on OAB. Why do this? Simple answer. It's the right thing to do by our patients. I think we all know that are listening to this webinar tonight. The most challenging piece of this is the how. So let's probe a little deeper into the whys. If you guys will bear with me for just a moment, I do have a personal why that I want to share with you, which will explain my over-the-top passion for the Navigator programs. I see this from two sides, as a CNO and as a patient. I'm very blessed to say that I'm a cancer survivor, and nurse navigation started with me in the oncology world, but I found out up close and personal the importance of patient education and being informed of the entire treatment spectrum. It gave me the reassurance that I had all the treatment options that I needed in order to survive. So we wanted to apply that same principle. UA wants to create the same positive patient experience for all of our patients. So we began with prostate cancer navigation program and then felt this service line should be not just limited to this disease, but we wanted to move on to another disease state, OAB. So at Urology Associates, we implemented our own OAB algorithm years ago, which we took from AUA guidelines, and even with that in place, we were still seeing a significant loss of OAB patients. In fact, in 2014, we were still losing 54% of our OAB patients, and only 3.3 of these patients were making it to advanced therapy. These numbers told us that our patients were not being offered the same options to get better. We had to take it to the next level. So how did we answer? We took it to the next level by creating our algorithms in a patient-friendly format, and we used them as patient education tools that we wanted to be printed out on the patient's office visit summary. All along, we were hoping that patients would take this summary home with them and actually look at it and study the possibilities of how, hey, I've got hope, I can get better. If this doesn't work, I have something else to do. So then our pathways in time evolved into two separate pathways. Here you see the female control pathway, and then we have a male bladder control pathway. Next, I wanted to show you that you'll see Dr. Abel here showing that we actually framed our pathways and put them in every exam room for the patients to view. I've actually had comments from patients that while they're waiting on the doctor, they find where they are on that pathway and the doctor comes in to see them. And they start talking with the doc and say, hey, this is where I am. Are you going to do this for me next? And then I've also had comments from our physicians that say, when that patient is in the room with me, I'm looking at that pathway to see this is what I want to do next for that patient. So for a minute while this slide is up, I want to pause to stress that Dr. Abel has been instrumental in this program. She had the dream and trusted one day that with perseverance, this would come a reality. But we realized that this would be a long journey and that protocols and pathways are words on paper. It starts with physician buy-in, but it needs an entire operational team from CEO to CNO on to make it happen. So we know most patients progress through the treatment pathway far enough to be prescribed medications. But unfortunately, 72% discontinue meds after 6 months. The key reasons for this, lack of efficacy, and they don't tolerate the side effects. So 72% of a lot of patients is a lot of patients. what happens to these patients? Some of them may progress through a pathway, and again, some of them are lost. So let's move on to the how-to. I'm guessing that every one of the physicians listening to this webinar are probably set up differently in their practice. At Urology Associates, we have a strong governance structure that supports our culture. And our culture of the group is quality, and we are patient-centered. So I'm guessing about now, your next question is going to be, what's our pay structure? Our pay formula is based upon production. So how does the program begin? Like anything new, it begins with a concept. New concepts are taken to a committee at Urology Associates, and the committee is comprised of physicians who volunteer to serve on that committee. So in this case, the Performance Improvement Committee is involved, and the Performance Improvement Committee reviews the concepts and submits recommendations to the board for final approval. Once the board approves the concept or the protocol, whatever it is the PI committee was looking at, then that goes to administration for further operational design and actual implementation into the practice. So in the case of OAB, Dr. Abel, again, one of our OAB champions, submitted her OAB algorithm and program concept to the PI committee years ago. And where we are today, years later, after trials and revisions and dinner meetings and mailers and ups and downs, the PI committee with board approval determined that we were moving forward in the direction of value-based medicine, and we were going to hold providers accountable to our approved algorithms. Honestly, we had talked the talk. It was time to walk the walk. But let me stress again, you all, educating physicians on the algorithm and the protocol alone, it didn't work. With all due respect to physicians, we understand they don't like to be told how to practice medicine. You may hear they express concerns that a program like this, urologists may take their patients from them. They may lose office visits. All of these issues would make any provider nervous, right? Redirect them to the facts of your practice. So what I would address with these concerns, I would remind the provider that last year we saw 10,558 OAB patients and lost 54% of them after the first visit. Where did those 54% of those patients go? They didn't go to another UA physician. They either went to another practice altogether or they just gave up seeking help. So this program will help keep those patients in the practice, which is better than any loss for an individual. Encourage the mission, being patient-centric. It's truly all about the patient and their satisfaction. So in our practice, the patients belong to the practice, not the individual physician. With that being said, we felt by adding another service line or another layer to our healthcare team to assist the physicians, we could satisfy our goals to retain patients and to improve quality and patient satisfaction. The new member of our team would be a nurse navigator. So now we had board approval, but we still wanted more buy-in. I needed to name myself as the first UA OAB navigator into a pilot program to prove our concept. I needed to provide measurable data to our physicians. So 2 of our OAB champion physicians agreed to this plan, and I spent about 2 hours a day for about 3 months navigating these patients myself. Looking back at it, not only did I thoroughly enjoy this, but I think it gave me more credibility with our physicians, and it obviously gave me hands-on experience to develop our operational plan. But even with all of this, are navigators for everyone? I'm sure there's practices around that don't have a navigator in place, and their providers may offer a comprehensive treatment plan to the patient and meet the patient's goals. Does it mean it's a temporary fix? Without my own patient experience, I may have been more skeptical earlier, But again, when you're faced with a diagnosis that you don't want to hear, I feel that would put most anybody in the mindset to, for lack of better terms, go run in a bunny hole and hide. Even though I felt knowledgeable as a nurse, I heard and saw what others with the same diagnosis were undergoing. I wondered, why did I not take that pill? Why did I not get that chemo? Maybe my doctor wasn't as good as theirs. So from the oncologist, I heard my treatment plan, and I heard my 5-year and my 10-year survival rates. From the nurse navigator, I got more individual hand-holding, attention. I call it, I got my education, my motivation, and my inspiration from my nurse navigator. I learned where I fell on my own personal pathway, and it was due to my staging and my receptor type. So I didn't need every cancer treatment known to man at that time. So my navigator was a health coach. They offer a sense of encouragement and hope and peace to any diagnosis. So needless to say, I'm here to testify that nurse navigation is a solution and not a Band-Aid. This slide represents our Advanced Continence Center model at UA. So this includes every urologist and every advanced practice provider at the practice at every site. So we feel that we need to make our office visits convenient for our patients. Our patients enter the practice at the office and with the urologist of their choice for their initial OAB diagnosis. Then the navigator assists the primary urologist and the patient along the pathway and will refer them to an OAB urologist as needed if that primary urologist is one that does not perform an advanced therapy procedure. Once the goals are met, that patient can return to their primary urologist. One thing for sure, as you can see in this slide, the team is made up of many members. If you'll notice, the patient and the OAB navigator, they are in the center. It takes the entire team to make this program successful, including the patient. So don't lose sight to engage that patient in performing their own role as a member of their own healthcare team. As we all know, that's another step in healthcare trends. We've got to hold patients accountable for their health. So who do you hire as your nurse navigator? Be patient. Please hire the right person, not the degree. Take the time you need to talk to people, to see what they're about. You can train skill sets. You can't train the intangibles. You can't train or teach integrity. You can't teach passion. You can't teach somebody to love to be on the phone 8 hours a day. Find the right person for the job and then train them to be your OAB nurse champion. So here's my basic algorithm that I created back in February of this year. Obviously, I've tweaked it several times since then. I think one of the things that I've learned is the only constant that I know of is change. So we can discuss this in more detail later during the Q&A session if you wish. And this also may trigger some specific case discussion that you want to talk about during my navigation experience. Results. I know you all need measurable data to carry back to your decision makers. There's a few different ways we want to measure results. Remember, we want to measure value, quality, patient satisfaction, as well as to measure patient retention and, yes, increased revenue. So let's take a glance at this slide. I know it's a busy slide. We're not going to go through everything, but what I want you to see from this again is that this has been a work in progress for years, and it's ongoing. But the important thing I want you to note here is that we have tried several things, and yes, with our increased efforts, as you can see, the numbers were going in the right direction. So in greater detail, this slide is going to show you the volume increase across the practice, not only by the 2 physicians in the pilot study. The OAB navigation was the buzz. It was the buzzword. So let me tell you, the navigator should be utilized not only for OAB patients through the pathway, but we need to be able to ensure that the orders that the doctors order, that they're followed through with. By that I mean Navigator follows up on advanced therapy orders. So say a physician orders a perk. That Navigator is going to follow that patient to look for that 50% improvement so they can move them forward to stage 1 or final implant. The Botox patient returns in 3 months for a follow-up. The PTNS patient returns in a month for their maintenance. If a decision for surgery has been made and the patient and the doctor have gone through their informed consent, I think especially in large practices with multiple sites, we tend to lose patients. It's a shame when a scheduler calls the patient's not home, they leave a voicemail, and the patient never returns the call, and they're just lost in space. So many times, this is just so easy to happen. So this is where your folks that board your cases, your nurses, your pre-certing staff, your front office staff, literally your entire office is going to lend their effort towards the success of this program. And I don't want the primary focus to be on increased revenue, but we can all do the math. You see these numbers. With an increased effort during the navigation pilot study alone, physician reimbursement increased greater than $90,000, which didn't include facility fees when we utilized our ASC. So with this effort, this program paid for itself with some change left over in less than 3 months. I don't want to go without mentioning PQRS. It's another effort to answer the call to value-based medicine. To meet PQRS requirements, we are required to meet 9 measures in 2015 before being penalized for noncompliance in 2017. 2 of the many measures that we can choose are related to urinary incontinence for women ages 65 and older. These are measures 48 and measures 50. But just to note, physicians are required to perform the assessment and to document a plan of care every year to successfully meet this requirement. So I'm betting that all of you represented tonight that have practices, you all use the BPH symptom score form. Well, we created the UA-OAB symptom score form. So for us, this form replaced the common bladder and bowel survey form. So when a patient comes in, this survey is given to the patient at every office visit to be completed. If for some reason we miss one, the nurse navigator will go over this form with the patient. And then on the back, you see the area that's grayed in. That's the nurse worksheet. So that's where she makes her nurse notes to refer back to when she is staging the patients and knows when to call them back. This form is another way that we measure value. So at our practice, we utilize this form to score and trend the patient's condition at every phase during their OAB trajectory and actually measure the patient's satisfaction and value of care. So this information, we can use it internally for our own studies and audits as well as data for third-party payers. So I encourage us all to use tools to help us improve upon our process and our quality. Next, we wanted to include a checklist. I know all operations people like lists. So this is a list that, again, gives an overview of our process over the last decade for you to look at and add to or take away from, whatever might be of most help to you. So in closing, everybody, I want just to stress to keep focused on the goals. Patient satisfaction and quality and patient retention. To meet and exceed the patient's expectations is what we're going for. So if a patient chooses to see a provider at your practice, that patient belongs to the practice, not only the individual. Every one of our patients are our VIPs. I like to refer to a couple examples just for thought. If you all have a prostate cancer patient that needs a robotic prostatectomy and you're not the one that performs that, you're going to send them to a partner that does. In a cardiology practice, if a patient comes in to see a cardiologist and they have an electrical problem, that doc is going to send them on to an EP doctor for treatment. same concept. We do whatever it takes to get that patient to the right place for the right treatment within the practice. So present this as a service line to the physicians. Let us assist. The navigator and the rest of the team are manning the production line for the physicians. Let us take a workload off of the physician and get the appropriate patients to that physician in the OR. Implementation begins with a unanimous physician support. It goes through administration for implementation and development and analysts. All of that, it takes a process. Patient navigation is the new norm for healthcare. And nurse navigation, in our opinion, with the patient's openness to this program, combine it with our guidance and support from the whole team, we feel that it's the key for successful treatment plan for that patient to maintain independence and a quality of life. And this is for every patient at every age. So I want to thank every one of you for your time and attention, and I hope you guys are excited about this program as we are, and I am happy to take any questions that you may have at this time.
Thank you, Beth. Our first question is, how do you follow up with patients that will not return your calls?
Great question. When I have a patient that doesn't return my call, and let's say the physician ordered a procedure. I can't get a hold of that patient. I try their emergency contact. If all else fails, I may have to send them a certified letter. There are ways. You just keep digging until you find somebody that will respond.
Okay. Let's see here. Do any of your physicians get angry when your navigator first started calling their patients?
I don't know that I would say angry. I think concern is a word that I would use. And again, I understand change is hard for all of us. But what I did was redirect that patient into telling this person that we had 10,558 OAB patients last year, and we lost 54% of them. So nurse navigation. The nurse navigator is not practicing medicine. We're following standing orders from the doctors. We are going to hopefully capture that patient in the practice and move that patient along. If the physicians are afraid of losing that patient, I would rather lose an office visit or lose a patient to someone else in the practice than lose that patient and not take care of that patient. So yes, there has been some concern, but it's all about redirecting and going back to this is the new normal, and we just have to keep going and reiterating the positives.
Next question. I think there's a couple questions regarding this topic. Whether or not you have a clinic to navigate your patients, or do you do it all over the phone? And one of the other questions that was similar to that is, do you meet with all your patients face-to-face?
No, our nurse navigator does not have a clinic, and yes, all of the contact is via the telephone. So you'd be surprised how much you learn about a patient over the phone. They're not in a doctor's office, and they're not stressed. They don't see that white coat, so they don't have white coat syndrome. So you've learned so much about that patient and their fears and their desires. And, you know, I had the time. I had the 15 or 20 minutes just to hear about it all. And I think that built trust with the patient, and that, you know, that helped them to trust me to help them move along to the next step.
Next question. Do all patients with the diagnosis of incontinence go to the nurse navigator, or just your OAB patients?
Well, this is what we do. Everybody that comes in to see a physician that gets diagnosed with any of the frequency, urgency, incontinence, even retention patients, those are the patients that get the OAB symptom score form. So it starts there. all of those forms are sent to my nurse navigator. She goes through all those forms, and then I monthly give her a report of all new OAB diagnosed patients. So she works a report, and she works with those surveys to contact the patients. So we have a lot of incontinence patients, whether it's urge, stress, or mixed. We look at them all.
Next question. How do you handle when your patients are unable to afford the treatments?
We have several different ways of looking at that. Obviously, we have care credit in our practice. We certainly have to do the same. We have to offer the same thing to every patient, but we can't give something to one that we can't give to another because we're all under contract with insurance companies. So we do offer care credit for our patients so that they can pay back little by little and get the treatment that they so desire.
Are your navigators LPNs, RNs, ARNPs? Can you clarify kind of the role of the navigator and what their credentials might be?
Our OAB nurse navigator is an LPN, and again, I wasn't going on credentials there. I was going on the person. Our navigator had been our phone triage nurse for over a year. I knew she loved to be on the phone. I knew that the doctors were very impressed with her work with our patients over the phone and her documentation. She was just a total package. So it wasn't about her degree, it was about her person. And she learned OAB. We let her shadow our OAB champion doctors. So she's learning all about OAB from male patients, female patients, from our OAB physician champions.
How do you encourage or facilitate patients to be in charge of their own care?
Great question, because that's what we're all faced with. If I'm talking to one of my OAB patients, obviously I refer back to what we talked about early during this webinar. If you have OAB symptoms, at first they're just bothersome. Later on, they can get worse. Other conditions can go along with OAB. So I try to educate a patient on, you know what, if you have this chronic illness, it's not going to go away. You have to play your part to help yourself. So we want to avoid all of these things that can happen down the road on your own health continuum. So it's all about education. It's about telling them what they're facing, telling them what they can do about it, telling them, just giving them options. But it's a whole process from start to finish. It's not just the diagnosis. It's about really explaining everything about that to put them in their role.
Kind of a two-part question for this next one. During your pilot program, how many hours did you spend navigating the two physicians' patients? And then when did you hire your full-time navigator, and how has that been going?
I would guesstimate that I spent about 2 hours a day. Now, obviously, I navigated these patients along with my other duties, so there were days that I would work on it more than others. But I would say an average of a couple hours a day, 4 to 5 days a week. And there were patients that I would spend 15 minutes on the phone with, and some I would spend 5 minutes on the phone with. It depended upon the need of that patient and how much they wanted to talk. So we actually hired our full-time nurse navigator, and she started working full-time September 1st. And it's going great. I can honestly say she's still in training, but I'm sure most people out there listening want to know how that's going. So in 17 days, I have looked at the numbers and looking at what all she's already done. She's booked 10 stage 1s and stage 2s, 5 perks. I mean, the list goes on. Just the preliminary figures, if I counted the facility fee, we'd be pushing 6 figures already in 17 days. To me, that's a wow. And along with that, I can't put a number on goodwill. Can you imagine what these patients are feeling like when we pick up the phone and call them? Patients are used to picking up the phone, getting a voicemail, and say, I'm in clinic right now. I can't talk to you. I'll call you back after 4 p.m. today. These patients are wowed by us taking the time to take care of them.
Next question. If the physician schedules are overbooked and there are long wait times to get in, how do you solve this, or how have you solved that if that was an issue within your practice?
Well, I can probably say that would go for any practice. There's days when, you know, the doctor's schedule is full and the doctor will say, work them in, work them in, work them in. As a nurse, obviously, if I'm working that position, it's my job to get those patients seen and to get that surgeon out to the OR on time. Patients always come first. So if we're continually overbooking and it's an issue, then we may need to let one of our advanced practice providers see a few of those patients for that physician. But usually patients that book with those doctors, they want to see the doctors, and that's okay. So there are going to be days we're overbooked. I mean, that's just part of the business. But we do need to be very considerate. Patients' time is as valuable as our surgeon's time, and we don't want to keep the patients waiting. But you know what? In all honesty, all of you go to doctors. If you're going to a doctor that you believe in 100% that they are all about you and they're treating you right, you don't mind the wait.
Next question is about your measurement. Are you measuring patient loss now versus the 54% prior to the Navigator being implemented?
Kendall, would you repeat that question, please?
Sure. In terms of your measurement, are you measuring your patient loss now? So you mentioned that 54% of your patients were lost after the first date of service. Are you measuring that now that your patient Navigator has been implemented?
Yes, that will definitely be one of the analytical points that we will be doing. I probably will get that information quarterly so that I can report that back to the PI committee and the board. We're very fortunate to have an analytical team in the administration here that takes all of our OAB symptom score forms and pulls all these reports and puts them all so that we can actually measure these results and report them back to the board.
Okay, does your Navigator have standing orders, or where do they get the information that he or she knows who to call?
Absolutely. Our standing orders are basically our algorithm. So we know if a patient comes in from our algorithm and their behavior modification and they've had one med, we know that it's time to go to med number 2. If that patient wants to come back in and see that office, to see that doctor at the next office visit to be changed to med number 2, we make sure they have an appointment. And we don't want that appointment to be so far down the road that they just don't come back to see us. If that patient doesn't want to come back in to see that doctor for that medication change, we do have standing orders. So basically it's a checkbox of if a patient has hypertension or metoprolol, or if they're taking metoprolol or glaucoma. There are certain things that Dr. Abel and our board has given us that if any of those are yes, then they can't go on this med, choose this one. So yes, there are standing orders. Now, if they finish their meds, then it's time to go on to the next step of urodynamics or cysto. If that patient is ready to move on, we have permission to go on and set the orders, send the treatment planner to order that cysto and that UDS, and the physician can do the informed consent in pre-op or in another office visit. That's according to the physician and the patient.
Okay. How many hours do you think a busy 4-doc practice would need the Navigator to spend? Just an estimate.
In a 4-doctor practice, how many hours? Well, I was navigating 2 physicians and spent about 2 hours a day. Now, obviously, in my role, I was interrupted all the time. So, you know, if I was spending 8 to 10 hours a week without interruptions, if you were doing nothing but that, start at half of that.
Okay. We have time for just 2 more questions here. I want to be respectful of everyone's time, but there's an overwhelming amount of questions, and we'll make sure that they all get answered. How did your practice determine who the OAB specialists are? And if there was a specialist required to do all, and was your specialist required to do all of the third-line therapy options?
The practice didn't determine who our OAB specialists are. We basically have a list of the doctors that do advanced therapies. So a physician chooses, they want to go get trained to do InterStim therapy. That's their choice, and then they'll be on that list. So obviously we have OAB champions that do more implants than others, that do more Botox than others, that do more PTNS than others. Excuse me. That's the physician's decision on whether or not to become a specialist. We don't determine that for them.
Great, and last question. Can you share a little bit with us about how you've incorporated your pathway algorithm and other forms into your EMR for this patient population, or how you've integrated them into your practice?
Well, we began incorporating the pathway by having that pathway print out on the office visit summary. That wasn't the best way of doing that. So we have now created a brochure for our patients that basically it is all about OAB, and it has our pathways in that brochure, and it also includes that we're going to give them a personal nurse navigator with her name and her phone number. So when that patient comes to that physician in the Advanced Continence Center for that office visit, this is something that the doctors can give that patient to tell them everything they need to know and how we're going to help them. So that's really how the pathways are incorporated now for our patients. As far as it being in the EMR, this is working better.
Great. Thank you so much, Beth. And thank you, everyone, again for joining this roundtable discussion this evening. Questions that were not answered live will be addressed, and a reply via email will be followed up within the next 3 to 5 business days. Our next webinar will be on Thursday, October 22nd at 6 p.m. Central Standard Time. The topic is on sacral neuromodulation for gynecologists, delivered by Dr. Meena Jain. We will also continue tonight's conversation with a webinar on November 12th at 6 p.m. Central Standard Time on more talking points and tips on implementing care pathway by Dr. Colin Goudlock. To view our past and future webinars, please visit professionals.medtronic.com/advanced practice. Thank you for your continued interest in Medtronic products and therapies, and have a wonderful night.